Wednesday. I know it's the virtual day, and I know that that doesn't maybe go as well as some would hope for lectures. I hate it, and I don't want to do it. So, if it would be okay with you, we go until lunch today, and then we take the whole block Thursday morning, and we try to see if we can cut that time Wednesday. Fair? Is that okay? I'm not that interesting to talk to, listen to in person, much less over a video. So, let's try that. Second, you guys didn't have a test this morning, so we'll go ahead. Just go. Okay. We were talking about cardiology. We're going to be jumping back into cardiology, but let's try this. Okay, a 4-year-old who's an otherwise healthy child is in the ER with a fever. You hear a 2 out of 6 vibratory systolic ejection murmur. What are you most likely hearing? Yep, 4-year-old, otherwise healthy child in the ER who has a fever. You hear a 2 out of 6 vibratory or musical systolic ejection murmur. What's your diagnosis of what you are most likely hearing? A Stills murmur. Correct. What is that? Is that a functional murmur or a pathologic murmur? It's a functional murmur. Is a functional murmur good, bad, otherwise? It's totally fine. Yep. What is your first line treatment for SVT in a baby? Not the water, not the ice. What is that called? You're holding them upside down. Yep, or vagal. Yep, so getting them valsalva, you were vagaling. What's your second line? Ice in the face. What's your third line? Not yet. What's your third line? Adenosine. How do you give it? IV push, followed, is it fast, slow?
Fast.
Followed by? Yep. What's your fourth line? Synchronized cardioversion. What do you need to be ready to do if you do synchronized cardioversion? Compressions and code them. Yep. What type of heart block has PR interval that is unchanged but intermittently dropped QRS complexes? Second degree type 2. Yep. Duck, drop a goose. What is your underlying cause of a neonate who has a complete congenital heart block? What happened there? What happened that suddenly they have their SA node ain't talking to their ventricles at all? The mom had what? Had what? Yep, mom had a syndrome. What did she have? Lupus. Correct. Maternal lupus. Or Sjogren's syndrome, but I think most of the time. Oh, okay. Wow, I must not have been very effective. Okay, this is one of my favorite sections, is the cyanotic lesions. Super cool, I think. And did Dr. DeBoer teach you the hand? We both learned the hand method for these cardiac lesions. We don't know what we're talking about. Okay, so the cyanotic lesions, meaning that you have deoxygenated blood from the right going over to the left and out the body with no oxygen in it. So ways to remember these cyanotic lesions. The top, we'll call them 6. So your thumb, one big giant trunk. So truncus arteriosus, one big trunk. 2, transposition of the great vessels. We have 2 of these, transposition. 3, tricuspid atresia, 3 leaflets, tricuspid atresia. 4, tetralogy of Fallot, so tet, meaning 4 things, the 4 parts of it. And 5, my favorite, TAPVR, total anomalous venous pulmonary return. And then the 6 is hypoplastic, left hypoplastic, okay? So those are what we're going to be talking about. You guys look not as confused with that. I think the end is super cool. So those are ones we're going to talk about in detail. There's also Epstein's anomaly, and it doesn't seem to fit on the end. So if anyone has a great way to make that fit in a hand. I'll give you a little. The thing about that is, it is not in any kind of order that tells you which one is the most prevalent. So the absolute most prevalent one of these is going to be tetralogy of flow. There's a couple of things. You can muscle your way through this and learn this, or you can understand a little bit of the embryology about it. Do you remember the 4 parts of tetralogy of flow from last semester? Not a VSD. A VSD, overarching aorta, the writing aorta, yep. Pulmonary stenosis. Yep, right ventricular hypertrophy. I'm so glad you guys can read the slides. It's so great. However, the way to think about it is that when the baby functionally goes in utero, in embryology, from 2D to 3D, when everything is kind of wrapping around and forming, what happens in this is that the septum moves anteriorly. So instead of coming together and forming real nice like this, it moves anteriorly. So when I do that, and I move anteriorly as a septum, I have thus created a VSD. So this is what my VSD looks like, because I didn't form correctly, right? So I have this VSD. But now I'm pulled way forward. Which great vessel is pulled forward? The aorta. Correct. So I now have this overriding aorta with my VSD. Because of that, now way back here is your what? Teeny tiny pulmonary vasculature. Yep, so you have your teeny tiny pulmonary artery back here. And now, where does the pulmonary artery back up into? The right ventricle. So now you have this big old right ventricle, okay? So all of that becomes because you have this anteriorly moving septum, right? So you can force function your way to memorizing that, or if you think about what happens anteriorly, and you're like, oh, VSD, big aorta, teeny tiny pulmonary vasculature, and it butts back up into your right ventricular hypertrophy. If you ever hear something called pentalogy of flow, that's when you have an ASD as well. So you can have all of those things too, pretty uncommon. Oh, I said something. So those are the 4 things and the kind of the embryology of what is happening. Now, which one of those 4 is that rate limiting step? Of all of those, which one determines how bad this kid's TET is? Your pulmonary stenosis. Why? Yeah, that's functionally your rate limiting step. If I can't get anywhere past that pulmonary vasculature, I can't get any more oxygen, okay? So just a picture of what my little dance looked like. So the pulmonary stenosis is going to be that rate limiting function. It determines how severe this is. So you might have just a barely overriding aorta, or you might have significant enlargement of that aorta and a small pulmonary vasculature. And so over time, that increase in that pressure over the course of several months is going to then determine how badly affected this child is. And so they will have, over time, those progressive TET spells, or these hypoxic episodes. So as the child gets more hypoxic, it makes sense that they would start to have some of these symptoms. I don't have any oxygen, therefore I am agitated, I am restless, I am irritable, I am inconsolable. And now I'm starting to hear that loss of murmur because now I don't have that movement across the pulmonary vasculature, and I don't have it across the VSD. So you're seeing less of a murmur as everything starts to clamp down. So what do I do then as a compensatory mechanism if I'm a child? I squat way down. That pushes blood further into the right side and it forces it up into the lungs. Okay, so that's what's happening with a TET spell, and why you'll see kids drop down onto their knees. Does that happen then as a super tiny baby? No, yeah, this is way over time. So if they're trying to give you on the pants a question about TET, they're probably going to give you a scenario where you had a child that was recently adopted with unknown medical history and they do a squatting motion. They'll give you something like that because it takes a while to see that progressive pathology over time. A lot of the times when we see this in neonatal echoes, that's when we start saying, oh, we need to do these stage surgeries early, so we actually don't let them get to this point. If you are hearing this, most of the time, it's the rate limiting step, so that's the murmur that you're hearing, that pulmonary stenosis in that left upper sternal border. So you're thinking, wait, what about that VSD and that left lower sternal border? And you're like, sure, you're hearing that too, but the pulmonary stenosis is going to be what that pronounced sound that you're hearing is. Certainly for any of these cyanotic lesions, if you don't have enough oxygen carrying capacity, your body is going to compensate by making more. So these babies that have these cyanotic lesions are usually going to have an element of polycythemia with them because they're having, that's a compensatory mechanism. So if you had a CDC, you'll see increase in that production. You're going to see if you had that prolonged amount of unrepaired heart, that you'll have that right ventricular hypertrophy kind of pop out on that side, making that boot-shaped heart. So that's that, if you're word associating, tetralogy goes with that boot-shaped heart, and then again, because it's bigger, you're going to see that on EKG as well. So any of these cyanotic lesions, so anything that was on that hand, you're going to want to think, I need to keep some mixing capacity somewhere open to be able to get this oxygenated blood back to the body, or I need to get deoxygenated blood to the lungs, right? So I need to be able to do that. So these ones are ones where PGE, prostaglandin are going to be used to make sure you have that mixing. The surgical repair will happen in stages. You can't just suddenly close that septum or suddenly remodel the aorta. It's a very stepwise stage procedure that you do over time. The thing to know about this one too, it's one that we do the prophylaxis for endocarditis. We don't do that a lot in kids as much anymore, but this one does have prophylaxis around the surgery time, and if they have a residual VSD, you're going to continue to prophylax them indefinitely. Most of these kids, TET does really, really well because you're kind of ultimately fixing that one embryologic defect of that move forward. Even though it's in the stage repair, this one does really, really well. They go on to do incredible things. Think about your most famous Olympian that has TET. Do you know what I'm talking about? Shaun White, yeah. Like, he had TET, he did pretty well for himself, right? So they go on to be fantastic athletes, live very, very normal lives. Weird elf-shaped boot looking thing, that's what you're looking at. That big, butted out ventricle. Okay, transposition of your great vessels. So this would be finger number 2, where you have your 2 great vessels when we are talking about that mixing. And again, the embryology is really interesting to understand. So as it's all coming into a 3D model, when the vessels are coming down and meeting the ventricles, at the very last moment, there's a twist. And so when you don't have that twist at the very end, you then have your great vessels on the wrong ventricles. So they didn't quite get that signal to twist at the end. So suddenly now you have the oxygenated, you have the aorta coming off the right side, deoxygenated, and you have your pulmonary vasculature coming off of the right side. No, left side, so backwards. You guys can see that. Wrong vessels to the wrong ventricles. And so you have to have some sort of mixing somewhere, or they are not compatible with life. What happens in these babies? Do you remember what the blood concentration of oxygen was in mom in utero? Yeah, like 55, 60%. So it's pretty low. If you in this room were at 55 or 60% oxygen, what color would you be? Kind of blue-gray, yeah. So babies, when they come out, they're kind of, what color? Blue-gray. Yep. So when these babies come out, you expect them to pink up, right? We do the APGAR at what minutes? 1 and 5, yep. So we do that APGAR, and we're just waiting for them to pink up and be not cyanotic. And these babies don't pink up. So they stay at that 50 to 60, and all of a sudden you're like, they are not pinking up at all. Something is not great. Right? And if there's no mixing, then you see that, and it is really bad. Yes, sir. Say it again. Yep, so they'll be breathing, everything is moving, and they are just not pinking up. Yep, so this is a true medical emergency, if they don't have some sort of mixing lesion somewhere else. So you have to have, this is the times where you're like, one thing went wrong, didn't twist, let's hope that something else went wrong. But we have a VSD, an ASD, a PFO, a PDA, something. We need some other way to mix that blood. So if you see this lesion, and there is no VSD, ASD, something here, everything looks purple because everything is not how it should be. So we have to get that so that they won't pink up, and they will start very quickly to have then respiratory distress. Yes, ma'am?
How long
How, if we don't intervene, they don't have very long, like hours. If they do have some sort of mixing, they can kind of hold on for, depends on what else is going on, but they have several hours or days, NP-wise. Kind of a loaded question. Happy to talk offline about that. Okay, so they end up with a 0 on their EPR, don't do well at all, and you need, yes, and so you need some sort, so PGE for these babies is absolutely of the utmost importance because you have to keep that PDA open. That absolutely has to be there. Surgical repair is going to be of the utmost importance for this baby because you have to switch the sides. The problem when you do this surgery is that you're messing with you're thinking, oh, I'm just changing the septum around, this should be no problem, but you're manipulating that and it doesn't particularly grow very well with the child, and so they don't usually have a very great outcome with this. If they're not repaired, or if they have a staged repair where the heart is compensating, you see an egg on a string because you are seeing the microphone fall down. You're seeing a compensatory problem from both of those vessels, so both of the ventricles end up bigger, and so it looks like you have just kind of dropped, and there's literally an egg, and it's just big on both sides. So if you see that, that would be your thing to memorize with this one. So egg on a string, weird egg on a string in that heart. You see just big giant heart, both sides are getting that pressure. Tricuspid atresia, so that 3-leaflet one. When we see this, the way to think about this is that you have these 3 leaflets of the tricuspid valve, and something went amiss, and so it didn't form at all, right? And so do you remember from block 1, if I said no flow, you had no grow. And so if you had no flow across that tricuspid valve area into a right ventricle, you functionally do not have a right ventricle that then forms. And so in this, you have this really complicated thing. Think of this like a house where you had a poor architecture where you're missing a door to one of the rooms. And so as the compensatory mechanism, we said, okay, well, let's make some windows and we'll crawl through the windows to go around into that room. So that is the very complex thing of what is happening if you do not have a large right ventricle. You will say, I'm going to go from the right side of the right atrium, I'm going to go across into the left atrium, then I'm going to go down into the left ventricle, back across into the right ventricle, and then up to the pulmonary vasculature. Right? So we've taken these windows and we've gone completely around because we can't go through the door that was the tricuspid valve. That's what is happening in this. So very, very complicated. And so in this case, you really, really want and need an ASD and a VSD to functionally be those windows that you can kind of crawl through to get back to the point where you have access to that pulmonary vasculature. The other option you have with this is to make sure you have a PDA open, so using prostaglandin again to get that mixing, to be able to shunt that blood back. Very difficult stage surgery again. So the way to think about tricuspid atresia would be the same way if you think about hypoplastic right heart. So those are kind of synonymous. So don't get those. It's a little bit, we'll see hypoplastic left heart. So this is functionally the hypoplastic right heart. Yes? If you don't have a VSD, then you have to have that PDA until you can have some sort of stage repair. Your truncus, so your thumb is one big giant trunk. So whereas you maybe got the twist, you didn't get the septum between the two vessels to be able to have your 2 large vessels. So you just have one giant trunk that it forms between the 2 outflow tracts. Most of the time, this one does okay right after birth because it has an obligatory VSD that goes with it, because nothing formed down that middle of the septum. So you have mixing. However, it doesn't bode well for future correction because you're trying, again, as an architect, you're trying to put a wall there that wasn't there naturally, and so it doesn't grow with the child. So their outcomes of this aren't particularly great with truncus, even though they do better than, say, a transposition right after birth. So you're looking, one giant trunk, the mixing across that VSD. Again, you can use PGE. If you do that, you get additional mixing. So they are, again, blue babies. You get this additional mixing when you have another conduit of that. But again, they don't do very well even when you're trying to create that false septum. That one's probably one of the least that we see of all of the anatomies. And then my favorite, embryology is so cool for TAPVR. I don't know why I have all these weird favorites, but so when the pulmonary veins have formed, there's 4 of them, right? So you have these 4 pulmonary veins, and they look for these growth factors. And there should be a growth factor embryologically that is from the left atrium to say, hey, pulmonary veins, you 4 go down and attach to that left atrium. And that's what they're looking for. So when these 4 pulmonary veins don't have that, they just look around and think, I don't really know where else to go, so I'm just going to attach right here. And that right here could be just about anywhere. That could be the right atrium. It could be the liver. That could be the superior or inferior vena cava. They just go around and look to attach somewhere. And usually that somewhere is not the left atrium, so you have the return of oxygenated blood going to not the left side of the heart. That's a bad day. Something like that, I said that. So you must have an ASD then to be compatible. You have to have that mixing to be able to go then to the left side of that heart. So this is where you see it. So TAPVR can be anywhere. It's returning the pulmonary vessel or pulmonary veins are returning to the incorrect place. This is one though, unless you know where the anatomy is, you need to be very careful because this can get obstructed. So if you're thinking about this, if I am the pulmonary veins and I'm returning to the liver, let's say, now I'm returning to the liver instead of a chamber that has room for blood. So now I've just increased that blood flow, and now I'm obstructing because I'm trying to put blood into the liver. So if you have PGE and you're increasing that flow, you can have an issue where you end up completely obstructed. So very cautious, make sure you know where this child's anatomy is before you give PGE in this case. But the surgical repair is really cool because you basically can take these 4 pulmonary veins and say, hey little guys, good try, you went to the wrong place, pull them up, move them over to the left atrium, and we continue on. So they actually do really, really well. So super cool anatomy, super cool embryology, and a really relatively good outcome compared to all the other cyanotic blue babies. So I secretly love TAPVR. This one though is so sad. Hypoplastic left heart. So we talked about what was hypoplastic right heart. What's the other kind of name for that? Yep, tricuspid atresia. So for this, when you have hypoplastic left heart, what do you think doesn't form here? So good thought of bicuspid. Something is causing, potentially that could be that, something is causing the left ventricle to not form correctly. There's actually several different causes. You can have a failure of all kinds of things. Mitral, you can have different aortic hearts that don't fail. The bottom line is, for some reason, your left ventricle is a little puny little thing and it doesn't form correctly. And so if it's not forming correctly, that's your giant powerhouse that's going to move most of your blood out into your periphery. So if you don't have that, you are at a complete disadvantage. This is going to be the reason that most children with congenital cardiac issues actually do pass away. It's going to be a hypoplastic left heart. And so yes, you do want to keep the ductus open while you're doing this. And this is a really cool, there's the stages of this surgery are really, really interesting. So if you ever want to deep dive further into Keith's cards, happy to do that with you. But basically what eventually happens is the heart becomes, instead of a 4-chamber vessel that is going, it functionally, the left side just gets sacrificed and the right ventricle becomes the ventricle that is used for the rest of the body. And so you end up with a series of procedures that makes your right ventricle your left ventricle. The problem with that, over time, is that the right ventricle was never meant to be a left ventricle. And the right ventricle is not used to, nor designed to be able to have all of that pressure, the systemic pressure, backflow against it. And so over time, that right ventricle ends up getting bigger and bigger and stretched out until the point where you end up with heart failure from that. So super cool in the way that they have been able to save these babies, but eventually all of these kids will end up needing a heart transplant. I think I said most of that stuff. So you have a teeny tiny little left ventricle there. And this is the one you need to think these are the sickest of the children most of the time. Epstein's anomaly, our last one. Do you remember what can be the cause of this? If mom is taking this drug in pregnancy, what causes this? You're thinking, I know I took Major McCampbell's psychology or psychiatric course. It's not an SSRI. Lithium, yes. So lithium can be the cause of an Epstein's anomaly. And what is not forming in an Epstein's anomaly? Remember? Is it on the right or the left? It's on the right. So in this case, you have, again, a problem with those tricuspid leaflets. And they are functionally forming way too low. And so you have part of the right ventricle that's forming up in the right atrium. And so functionally what this looks like, if you think about this, it's like a dude that went to the gym and only did arms and chest forever and never did leg day. So you have this really giant right atrium and this teeny tiny little right ventricle, right? So that's like somehow in my brain it's like big old Mr. Epstein at the gym. I never did leg day. So you have this atrialized right ventricle. That's what that means. Is the leaflets are too low, and this teeny tiny then right ventricle. Because of that, you have this backflow, this leaky valve, backflow into the right atrium. And so you see all the things that are associated with that right atrium. Higher pressures there mean you're more likely to have an opening of that PFO you're not supposed to have, and a bypass of the lungs after birth. It also can mean that you end up with a right bundle branch block, depending on where that is going to be. Pretty rare, and having to do, when we see it, and the kind of the classic pants thing to know is that it can be due to that lithium exposure. And interesting though, is that it's a pretty, even with lithium, it's a pretty rare complication of that. And so if you have a mom who is on lithium for a bipolar disorder, lithium, is that first line? Is that second line? Is that third line? No, it's like the bottom of the lines, right? So if somebody is doing well and stable on lithium, it's probably because it didn't do well on most other things. And so the benefit to keeping mom stable on lithium outweighs the risk of Epstein's anomaly. So in this case, you leave mom, who is stable on lithium, and you watch for this anatomy to form this way. So it does not outweigh the benefits of the lithium. See what I mean? You have little atrialized right ventricle, so it looks like, do you know what I mean? No? Okay. And the teeny tiny functional right ventricle at the bottom there, you're thinking about that. It's a friend that let friends get neglected. That's what Epstein's anomaly is. So you see this global cardiomegaly again, right axis deviation because it is backflowing into that right atrium, and again your right bundle branch block. Okay. Box-shaped heart, and Mr. Jim. Weird box-shaped heart. So we had egg on a string with what? Yep. And you had boot-shaped heart. Tetralogy, yep. And now you have your box-shaped heart that goes with Epstein's. Right bundle branch block as a reminder. So all of these cyanotic lesions, the 6 of them. So again, what was the pinky of the 5? The pinky. My favorite. Which one was my favorite? Yep, TAPVR. What was your fourth finger? Tetralogy. What's your third finger? Tricuspid atresia. What's your second finger? Transposition. And your thumb? And the O, hypoplastic left heart. Yep, so all of those plus epsteins are candidates for prostaglandin to keep that ductus arteriosus open, to write PDA, to get your left to right shunting. Let's see, any of these things, just in general principles to take away from this, anything that's going to cause an increase back to the pulmonary vasculature can lead to that pulmonary hypertension or that congestive heart failure or pulmonary edema because you are over circulating those lungs. So a lot of times you have to take excess fluid off of these kids with a Lasix or digoxin until you're doing the stage repair. Otherwise they end up like those the elderly folks that you guys have learned so much about who have that CHF physiology. If they are non-urgent, so the one that we talked about, very, very urgent, transposition, if you do not have some sort of mixing there, that is not good. So if you have these non-urgent ones, I think tetralogy, your risk of anesthesia, I'm about to lose this again. Your risk of anesthesia and your risk of surgery is higher. And so you wait until the kids are a little bit older to start those staged procedures. So yes, you're emergent, not compatible with life, you're going to take care of right away. The rest of them occur 1 to 2 years old in these staged procedures to make sure that you give them every opportunity to be able to handle the anesthesia that's associated with this. If you do not treat these, so if you get test questions on your pants that have something to do with these congenital cardiac issues, most of the time it's because they have that rate limiting step of your pulmonary stenosis. So you have pulmonary hypertension or that over circulation into the pulmonary vasculature again, leading to your congestive heart failure or pulmonary edema physiology. Okay, none of you guys were as jazzed about that as I was. That's okay. I understand. It's the end of the semester. Which takes us then into some of our acquired. And the first one up is rheumatic fever. And at this point, you should be groaning because you've heard it in like 17 different classes, and that's perfect. And that means that it's been tested enough times, and you've heard it that it's going to be on your pants. And when you are getting tired of these topics, it means you know them well. So that's perfect. It's right on target. Okay. So in this, again, rheumatic fever is from a group A, beta hemolytic strep, which means group A strep. I know how to treat that. What do you treat group A strep with? Low dose of amoxicillin for kids. Perfect. So in this, there's a lot of times that different infections will make these antibodies that will cross-react with your cardiac muscle, right? So we already learned about one of those. We said, wait a second. So mom's antibodies from lupus, they were the ones that they went and targeted those heart muscle. And now strep can do it too? Yes, that's exactly what I'm saying. So strep will make these anti-streptococcal antibodies that will go over and they see the cardiac muscle, they see the cardiac antigen, and they will say, I need to go attack the valves of the heart. So that's ultimately what is happening with that. So pick a valve, any valve, they can do it really anywhere. What is interesting about this age, 6 to 15? Where have we seen that age before? The Centaur criteria. Oh my goodness. So that's why that age gets an extra point? Yes, because the most common, the most likely age to be associated with rheumatic fever is in this age range. So since their risk is higher, they get an extra point on the Centaur criteria. So that's exactly why. Perfect. So they get this infection. A few weeks goes by, they make the titer, so ASO, anti-streptolysin O titer. They make this, and now they have other symptoms that are going along with this. And now it's not just that they recovered from strep, they have these weird kind of, all these things that are going together to say what is going on. So when we see this, you are going, and you will need to know the Jones criteria. We're going to beat this into you. So you either need 2 of your major criteria, or 1 major, 2 minor. Those are the way that we're going to do this. Plus evidence of strep. So pick away that there is evidence of strep. Most people will end up getting those ASO titers because it's been long, several weeks ago, so they're probably not going to have a rapid strep that's positive. But you can look back historically and say, oh, I did have a rapid strep antigen. I did have a throat culture that was positive. Oh yeah, that kid did have strep butt, right? The perianal dermatitis that we talked about. They did have scarlet fever several weeks ago. Or you have an elevated evidence of ASO titer. So your major criteria then. We are in the cardiovascular lecture, so one of the major criteria is that this kid has some evidence of some carditis. So pick a carditis, any carditis. Do you have a new murmur? Do you have some sort of CHF? Do you have a myocarditis, a pericarditis? What's going on here? Second one is polyarteritis, right? Wait a second, we haven't talked about kids with joint stuff. Yeah, because it doesn't happen all that often. Kids are like Gumby, they jump around and like their joints don't ever hurt. Nothing ever hurts. And so now all of a sudden they have joint issues. So multiple joints that hurt, so that's weird for kids. You have Sydenham's chorea where they're kind of moving in those kind of strange patterns. Your erythema marginanum, you see pictures of up top, and then your subcutaneous nodules, which are down at the bottom. Which do you think is the most common associated with rheumatic fever of the major criteria? Yes, the carditis. Yep. That's what we see the most is going to be carditis, followed by the polyarteritis. Your other minor criteria is again up there, so some sort of EKG change. A lot of times that's just a prolonged PR interval that we see. And which type of heart block is that? First degree, correct. But really any heart block will do it. Continue to have those arthralgias. A true fever that persists can be something. Your elevated markers of inflammation, so evidenced by ESR-CRP, a white count that is higher. And then if you had a history of this in the past. So again, 2 major or 1 major and 2 minors is going to get you there. So just a different way of studying it. And most common, you're going to see carditis and polyarteritis for children. Just another picture of your subcutaneous nodules up top, and then evidence of the carditis and the heart block with the PR interval on the bottom. So yes, they're going to end up with cardiology for sure. First off, you need to make sure that we have eradicated the underlying and the causative agent. So when we're doing that, we've got to get rid of the strep infections. One of the first things they will do is a benzidine penicillin or bicillin or butt penicillin. That's the one that you will give the IM shot right into the rear. If they are allergic again to penicillin, certainly you're going to use something else with erythromycin. And this would be one of those instances that we do use aspirin. Wait a second, I thought we never use aspirin in children. Over here we do. There's a couple of instances that we do. This would be one of those instances that we use aspirin. Certainly you can use NSAIDs that are going to be less associated, so they're not as effective, but they don't have race. Do you remember from block 2, aspirin plus what virus caused gray? Varicella. Perfect. Good job. Another thing, for that severe inflammatory response with certain types of carditis will be steroids to help calm that immune system down. And then your long-term treatment. So the problem and the reason that we make sure that you guys know the criteria is that this is not a willy-nilly diagnosis, certainly not for children. So if you're just thinking, oh, I think they had some carditis and some fevers, and yeah, they had strep a little while ago, I'm just going to call it rheumatic fever. What you have functionally done is, to this child, they are going to be on antibiotics for the rest of their life. Forever and ever and ever on it. Okay? So this is a diagnosis that you need to have your friends involved in with pediatric infectious disease, pediatric cardiology, before we say, yep, we are going to do this forever, because they will get penicillin once a month, every 28 days, for a lifetime. So if you have a 2, 3, 5, 6-year-old, that's forever. Okay? So thinking about, do I really have the criteria? Is this really what the entity is going on right now? Because it's forever. A few words on pericarditis. We're talking about that inflammation of the sap around the heart We're talking about the most common viral etiology. Do you remember which virus is most likely to cause this from 1 to 2? Coxsackie, absolutely. What else does Coxsackie cause? Hand, foot, and mouth, exactly. Certainly you have your more rare bacterial causes, but going to be much more severe. And then you can also see any kind of pericarditis with different types of autoimmune diseases. When there's autoimmune diseases, you always need to think this could be affecting the child's heart in some way. So all evidence, you can have children that have lupus, you can have children that have RA, so any of those things can affect the kiddo's heart as well. Certainly depends on how much fluid accumulation you have. So if you have a little bit of fluid, or if you have even a lot of fluid that is accumulated over a long period of time, kids will adapt to just about anything. The problem is when you have a large accumulation of fluid that happens right away. And then the kid can't compensate. That's when they do very, very poorly. So that rapid accumulation is really what's going to cause you to have a tamponade physiology, and that is what's going to have them decompensate very, very rapidly. So things you're just to be aware of to make sure that you can still pick this up. Very similar to those adults. So any kind of chest pain. So if you truly have chest pain in a child, remember that's very rare, but if they are really saying, I have exertional chest pain, it's better when I sit up, worse when I lay down, some of those things. Truly, then the friction rub, so going to just kind of key you into those. And if you have a child just saying, I'm just lethargic, truly, I'm fatigued, that's prolonged, that's something to prompt you to look into the heart. On your echo, if you're getting that, certainly you will see that fluid accumulation that you are going to see the effusion of. If you have a chest x-ray, you're going to see a large heart where you see that cardiac silhouette. And then just as a reminder, it's going to be the same as it is for adults. The ST elevation, the heart is beating faster as a compensatory mechanism. And then you have that electrical alternans. If you think about this, because the heart that was sitting so close to the pericardial sac is now kind of sitting in fluid, the heart can sway. So with each beat, you have a big QRS and a little QRS, and a big QRS and a little QRS. And that is my electrical alternans dance that you just did. Certainly, you can always see if there's an underlying virus that you can capture. Because it's not just Coxsackie, although Coxsackie is going to be one of them. So COVID is another one. It's a different example as a cause to this, though it's much more likely it's myocarditis. And then your cardiac enzymes can be elevated as well. So very, very similar to that. As a reminder in your EKG, what that electrical alternans is going to look like. Large QRS, small, large, small, and that kind of swinging of the heart. Your treatment, certainly if you have a large accumulation or it is very, very rapid and you need pericardial synthesis, is a quick word of that. If ever you take fluid from a child, and really anybody, but if you take fluid from somebody, send it to the lab. For God's sake, do something with this fluid and then call your patient back, right? So if you take fluid, you take blood, if you take urine, if you take spinal fluid, if you take joint aspirate, if you take pericardial synthesis, whatever you take, for the love of God, send it to the lab. Call your patient back. And then you're trying to decrease your the inflammation around it. So what you notice, what do you see here that you give adults that you don't give children? What do you treat adults? Colchicine, yeah. Wait a second. So we don't give kids colchicine? That is correct. So that's one of the differences between peds and adults. You're not giving kiddos colchicine, just giving them NSAIDs. The things that you would think, maybe this is worse, are going to be worse. So certainly the smaller you are, so if you've gotten that theme by now, if you're under 6 months, that's probably a prognosis that you're thinking, that's not as good, right? So we had, let's see, what was another example? We had pneumonia under 6 months. Well, you've bought yourself a inpatient stay, right? We had pertussis under 6 months. Well, that's probably going to be a worse outcome. Very similar here for our pericarditis. And certainly if it's recurrent, if their little bodies are getting used to it and they're continuing to make these pericardial effusions over and over and over, it's going to be worse as a prognostic indicator. Yes, ma'am? I guess there could be a time where cardiology would give colchicine potentially, but it's not something at a primary care level that you would be doing. You're just giving insulin. Yep. So we are moving to hypertension. This always gets people. We will work through this together. What time did I start? Or is this a break? Is this break time?
9:35, ma'am. So in theory, we have 5 more minutes where you can go right now.
Let's go on break because this gets people every time, and then we'll finish talk fast so that you have one itself on Wednesday. I don't have to do it. Okay, hypertension. So kiddos, so we're talking about what is going on. So back from block 1, part of your well visit was to make sure you had a full set of vitals on these octopus children with all of their limbs every which way, right? But we don't start that until they're the age of 3. You don't get a whole lot of useful information on compliant hearts before the age of 3, unless they have some of the following. So if they were premature, then they probably had some sort of central line. They had a umbilical UVA or UVC, they had a peripheral indwelling central catheter, a PICC line, potentially something where their large vessels were manipulated. If that's the case, they're at a higher risk of having symptomatic hypertension. Some sort of congenital heart disease, renal disease, so anything that has intrinsically affected their kidneys as kiddos, you're going to start early with that, and then some of the other ones that should make sense if they've had a transplant, cancers, specific other symptoms or syndromes that are causing this, like we talked about with your neurocutaneous disorders as one of those elements. So under the age of 3, having something specific going on, but for the majority of kids, 3 is where you start this. It's the same as your adults of 5 minutes seated in a quiet position. If you get a 3-year-old to sit still for 5 minutes in a seated position, I don't know what you've done, but so good luck with that. If you're checking, make sure that it is an appropriate pediatric cuff size, and just a quick check of this. Most of the time, if you're looking at what should their blood pressure be, if you're trying to just do a gauge, systolic pressure, you would want 100 plus their age in years. So most little kids, you're thinking about 100. If you're, or their age, so say 105, if you have a 5-year-old, anything above that is going to be, that is a little bit high, but you're trying to do 70 plus 2 times their age for that lower limit. So let's say you have a 5-year-old, I would expect him to be for a systolic somewhere between 80 and 105 is the rough guesstimate for that. It's much like everything else, it is percentiles. So there is not a specific number. We're going to talk about how to read the specific numbers. I always lose somebody somewhere. But the specific numbers are not as important as their percentiles. So remember from block 1, if somebody said, my baby is 7 pounds and 15 ounces, I don't care all that much. I care much more what's the age and what percentile are they in, because that helps me determine if we are normal, failure to thrive, obese, etc. Similar for this. So if you then, with your percentiles, are less than the 90th percentile for blood pressure, you're normal for a child. If you are between the 90 and the 95th percentile, you are pre-hypertensive. If you are between the 95th percentile and the 99th percentile plus 5 millimeters of mercury more, then you're stage 1. And if you are that 99th percentile plus more than 5, that is stage 2. We're going to talk about what does that actually mean, how do you read this, okay? So when you use this chart, you need the x-axis, the y-axis, the x-axis, the y-axis, the x-axis. So you cross it like 5 times, okay? We'll walk through this together, I promise. First things first, the things that you will need to understand a pediatric blood pressure. You need, if they are a boy or a girl, you need how tall they are as a percentile, and you need their age. So you're like, well, that's weird. Think about blood pressure. Is blood pressure a function of weight or height? It's a function of height. What's the point of blood pressure? Pressure is to circulate your blood. What organ must be perfused? Brain. So everything about blood pressure is a function of height. Okay, so I have to know, is my boy or girl? How tall am I by percentile? And what's my age? Okay, so when we're reading this, the very first thing, and you're going to start with your x-axis. So, am I a boy or a girl? So the very top of that says blood pressure levels for boys by age and height percentile. So I've checked that I have the right boy or girl. So that is my X check, the very first thing. My next one is my Y check. How old is this child? So that is your first thing in age. 1, 2, 3, 4, 5, 6, doesn't matter. So let's pick the 3-year-olds, okay? So I've checked that this is a 3-year-old boy. So I've done my X, my Y. I go back up to my X-axis. So I have to have what my height percentiles were. So you cannot do a pediatric blood pressure without knowing how tall they are. Okay? So the next thing you will do is I have this height percentile. And they will only give you 5th, 10th, 25th, 50th, 75th, 95th, and 99th. Right? So that means that you are going to have to use your provider brain to associate which one is the closest. So if you have a kid that is at the 45th percentile for height, well, we're going to use the 50th percentile. If I have a child that's at the 30th percentile in height, well, I'm going to use the 25th. Right? So you're using your provider brain to say what makes the most sense height percentile-wise. Okay? So I said I'm a boy, I'm 3 years old, and I'm at the 50th percentile for height. And now I go down to where those meet. So for that example, you're a 3-year-old in the 50th percentile of height. You are looking at these 4 numbers, 91, 105, 109, and 116. That's where I'm looking at. That combination then is where I'm going to then go back to my y-axis. So now these 4 numbers are associated with my percentiles. Okay, so I did X, Y, X, Y. And so now, 50th percentile for this 50th percentile height 3-year-old is going to be a systolic blood pressure of 91, totally normal. My 90th percentile is going to be 105. So really anything under 105 for this child is that normal blood pressure. When I get then into that 95th percentile, I lost it. It's 109. So 109 is my 95th, and then 116 is my 99th. So remember, the 95th to 99 plus 5 is my stage 1. So if I have that 95th percentile, it's at 109, and that 99 plus 5 is 16 plus 5, it's 121. So if I have a systolic blood pressure from 105 to 121, that's my stage 1 hypertension. Anything then above 122, so 99th percentile plus 5, is going to be that stage 2 hypertension. Does that make sense at all? Okay, so let's say, let me give an example. If I on something said, give you this chart and said, what would stage 1 hypertension be for a 4-year-old and a 4-year-old boy in the 75th percentile of height? Okay, so let's see, we have a chart for a boy. We have our x-axis, our y. We've come down and said, okay, we're 4 years old. Now 75th percentile. I've come down here. These 4, what did I just say, stage 1? Just say stage 1. Stage 1. So stage 1, 95th percentile. So 112 to 5 above the 99. So 112 to 125 is going to be your stage 1 hypertension. So that is how you read pediatric blood pressure for all things. X, Y, X, Y. Do it 4 times to cross, okay? You need 3 or more of the readings, just like your adults. And again, children can also be very nervous, come to a doctor's office where they get poked, they get stripped down to their diaper and prodded by a complete stranger, so they can have this as well. The much less common entity is going to be a primary hypertension. Certainly that is in usually older children and associated with obesity. What's more common is that you have a secondary hypertension. Something in their anatomy or physiology is not correct. So something in there when they are younger, when they have higher blood pressure, so typically that's stage 2 hypertension. And then if they have something intrinsically, they were born with something wrong with the kidneys, they cannot regulate their blood pressure. So the vessels themselves are fine. It's not the same pathology as the adults, but their vessels, the renal function is not allowing normal blood pressures. So your first thing, if you get that elevated above 90 percentile, it's much like we had in block 1 with your growth charts. Redo it. Make sure you have the manual cuff with the right size cuff with somebody who knows what they're doing to be able to get that accurate blood pressure. If you still have an elevated and it's between that 90th and 95th, well, let's just take it again in 6 months. Maybe the kid had a hard day, maybe they were just running in, maybe something's going on. So let's recheck it in 6 months and give them some education. If you have your stage 1, let's check it in a couple weeks and still educate. If you get in that stage 2, it's much more likely that you have a pathology going on and they need to be able to see a specialist. Which specialist, you ask? Well, that's a good question. Again, it's usually not something wrong with this kiddo's heart or vessels. It's most of the time their kidney. So pediatric hypertension is not managed at all by cardiology. It's managed by pediatric nephrology. It's another big difference for kiddos. Things when you should just be like, oh, that's not normal, is if you have a normal sized child, so less than that 85th percentile for weight, so you have a very normal for age and stage sized child, it's much more likely that a true secondary cause is the reason for their hypertension. And certainly if they are into that above 140 over 100, much more likely that there's an underlying second cause. Things to think about. You know that if you have things like Turner syndrome, if you have a co-arc, if you already know that they have poor growth and have a chronic renal disease going on, if they have those neurocutaneous disorders that you already know about, if they have certainly a pheo, if they have something going on with their adrenal glands, anything that could cause hypertension, it's much more likely that that is the underlying cause of that secondary hypertension. Your labs, your workup as the primary care PA then is going to say, well, I need to see, are we losing protein from our urine? What is our kidney function? And what is the anatomy of my kidneys? So I need a UA, I need my CMP for kidney function, or at least a BMP, and then a renal ultrasound, also the renal artery, so that entire renal anatomy. So what am I losing protein? What's my kidney function? What's my anatomy? Those are 3 things that you're going to be doing. Certainly after that, you can start thinking, ooh, do I have a pheo? I've never seen a pheo, so if any of you have seen a pheo, call me. I've never seen one. Is it the thyroid? Because the thyroid can cause anything. And is there any kind of other vasculature issues? Is it so much hypertension that it has caused an issue with the heart? And then certainly what other things are they at risk for? So stage 1 then, you're going to do that education. When I say, what is that education? Well, it's going to be lifestyle most of the time. So the same things that you're going to talk to your adults about: diet, exercise, food choices, family habits. When you're doing medication, you are either in that stage 2, so significantly elevated, or you are symptomatic with stage 1, or you failed all of your interventions, or you have something else underlying, like a diabetes, that you really need to have this managed well. And this is kind of more for awareness, because nephrology is going to do this. But if you look at this, it's going to be different than your adults. Your adults where you're like, ACEs, ARBs, sweet. If most of the time these kids have something underlying going on with their kidneys, but their vessels are super compliant, it makes sense that your first line is going to be a calcium channel blocker. Harness what's working, don't go and attack what already isn't working. So you'll see kids that are on a lot of these things, but most of the time our go-to for kids are calcium channel blockers. The vessels themselves are compliant, kidneys often are not. Okay, we did. Sweet. That's cards. Let's go over to heme. So that